So it is an 83-year-old male who presented with progressive fatigue, dyspnea on exertion for over the last year. So significant past history. That patient has had CABG plus AVR with a 23 millimeter Inspira and the left atrial appendage ligation in 2021, continues to have AFib. And now EF is 55% and has a torrential tricuspid regurgitation due to annular dilation. You can see the good medical therapy that he's on. Platelets about 151. We'll talk later about that. EKG, AFib, and he had a cath with the right heart pressures. You can see moderate pulmonary hypertension, reasonable. So this is, we'll show the live echo later. Severe tricuspid regurgitation. You want to show the live echo now or no?
Live echo, please.
No, hold on. Let's
do a baseline echo.
Baseline. This is the baseline echo.
Yep. Okay.
You're showing the live now?
Sam, you want to call it?
Yeah, go ahead.
Yeah, they're showing live echo. You want to show live echo?
Yeah, live echo, normal LV function, dilated left atrium, RV moderate decreased, dilated right atrium, mild MR. He has a bioprosthetic aortic valve, which looks okay.
Mm.
The RV, right ventricle again, mildly decreased. We get a strain here. Pre-wall strain is -18.5. Global strain -16, so a little bit down. PISA will get 1.2.
Patsy.
Moderate down. TAPSI, yeah. TAPSI. PA pressure about 45 systolic. The dimension is 152, which is consistent with what they measure with the CT. And here we see the catheter, the delivery catheter that is in the apex, RV apex. Deep gastric image through the right ventricle to see the picture again on the RV apex where it's supposed to be. And this is the torrential tricuspid regurgitation area, almost 1 centimeter square. Thank you.
Okay, go back to the slides. Okay, this is our other echo. So, Sahil, what?
Yeah, so it looks, pretty dilated annulus there, but still within range for the Evoque device. Perimeters around 145. Septal, lateral, and anterior posterior dimensions look pretty good here. Just a question for the audience. Anyone would think about tricuspid clipping here, or how do you decide which patients go for Evoque versus TTVR versus TTR?
What does the panel think?
Well, I was just trying to see the gap distance. Maybe it went by quickly, but what is the distance between septal anterior?
Stam, coaptation gap, please.
There was not really much gap on this patient. Actually, he's was down wrist, so there's not much gap.
Okay, I mean, it's in
Gap?
play then. If the gap is, less than 7, it's feasible. You can talk about it.
Yoshi, how do you make the decision on Evoque versus TriClip in your institution?
It's a very difficult one and complex one, but I think we do look at the T-tier feasibility first, and then look at some of the other factors. If the patient cannot tolerate anticoagulation, if the patient already has a pacemaker, some of these factors will place them into the other boxes. But we tend to start with T-tier, and then for anatomical unsuitable cases, we tend to go to TTVR.
Great. So your first decision-making tree involves T-tier, and then if they're not correct, is that the understanding?
To a certain extent, yes. To a certain extent.
Okay.
I mean, torrential TR, some people say, maybe more suitable for Evoque for the TR elimination.
Got it.
I think also the location of the jet, if it is primarily septal anterior, I think you can get down to mild TR frequently with T-tier, but you can get down to mild TR or no TR with TTVR almost every time. So,
Any issues with morphology of the valve, quadricuspid versus tricuspid versus bicuspid?
Yeah,
Does that change your decision tree?
To a certain extent, yes. More than 3, I think the likelihood, unless if the jet's in a favorable location, you may leave some TR at the end of the case.
Yeah, I would say, thickened prolapsing leaflets, you tend to worry a little bit more that you may not get an ideal result with T-tier. We tend to do things differently. I think almost everyone, if they can, will get a CT scan, and we'll actually look at suitability for both transcatheter, TTVR, and clip before we make a decision and sort of present those options to the patient. How did you guys decide on Evoque, and did you guys consider T-tier here?
One other question is pacemaker lead.
Yeah.
Right. So, pacemakers, we've done a few cases with the pacemaker leads. It obviously is a little bit of challenge in both situations, whether it's a T-tier or you're doing TTVR. But we've had reasonable results as long as the pacemaker leads are pretty lax. We've almost never required to extract anything. So definitely in those cases, I think if you have good echo imaging, you can really get a good result with the TTVR device. We have a protocol here that Gilbert can sort of talk about. He's worked very hard on building this protocol for the tricuspid space, and obviously one of the leaders in the triluminate enrollment. So Gilbert, you want to say something?
Yeah, so I think now this evidence actually moderate TR, in the real world may not end up being moderate, and follow-up. So we really try to get down to mild or less with T-tier. And if we don't feel confident we can do that, we will go to explore TTVR option, I think. And obviously there's a trade-off, right? Everyone knows that with TTVR, there's high risk of pacemaker, high risk of bleeding. We need anticoagulation versus TR near elimination versus T-tier is very safe. Patient go home the next day typically, but there is a chance that the TR may return, because the patient may not be on optimal medical therapy already in the real world. So that's kind of the balance we discussed our heart team. So, if it's going to be a green or yellow T-tier case, meaning that, like you said, what Steve said, small gap, good coarctation reserve, what Manuka earlier said, thin, long and mobile septal leaflet, I think T-tier is a very, very good option, and I think most of the time you get good result. But once you get, to 4 leaflet, 5 leaflet morphology, and there have been data showing that you don't get as much procedural success, and also if there's a lead that shadows, or if there's the jet is around the lead that you cannot really put a clip next to it, then I think we should look at the replacement option as alternative.
Yeah, no, I think that's very important because, see, I always believe that the surgical repair and the transcatheter replacement is the best strategy or the gold standard. But, with time that has changed, and we have great repair options as well. And it all depends on, the patient, not one size fits all strategy. So this patient we thought is able to tolerate anticoagulation. We can eliminate TR and get a good result with the TTVR device.
So you can see that here, the CT scan, this is courtesy obviously of Edwards Life Science team. They have an excellent team to work up all these cases. We usually do the preliminary CT sizing in our own institution, and then if we think it's feasible, then we give it to Edwards team to do that. And you can see that it's pretty reasonably oversized, less than 10% on systole and diastole. And you can see that here, they actually deem it to be a green case. Next slide. And then you can see that's the little bit IVC and analyst offset. So you want to talk a little bit about that?
Yeah, no, these can make these cases a little bit challenging, but we have a very roomy RA there. So even if you have a little offset, I think we should be okay. And sometimes we've switched our access from the right to the left side, and that also depends on how the RA height is. If you have RA that is roomy, a little bit of offset almost never hurts you. But you will see we did a lot of maneuvers here. We have a lot of secondary on to sort of get to where we want to be.
Yeah. Next slide. So this is some of the angles on view. Next slide. And you can see some of the the procedural spin. We won't belabor. You've already seen the echo. So that's it. So I think we can maybe show where we are at. You want to start talking? Maybe let's see the device. Can we see the device actually to the audience and the group? So look at Floral first. Sahil, you want to explain what we've done so far?
So we get 2 axes, 2 vein axes. The main is on the right side as we determined on our CT scan. The left is going to be our ICE imaging, just in case. And then the first, why isn't this moving? Can you guys check? Yeah. So we check with our eyes, see how the images are. If everything looks good, we go ahead with the delivery system.
So this patient does have a prosthetic aortic valve and an LA eclipse, so that could potentially shadow the anatomy. So and you can see now we can play that.
So this is the tricky part. You want to have your Achilles point down and, make sure your wire goes right down to the apex. Now, obviously, if you have thick paps or if you have multiple leads, you have to be a little more careful. But in this case, I think we landed it right in the apex and the wire position was pretty good. Any comments there from the audience?
Sahil, what do you have for echo imaging? Is that both ICE and TE? Do you use them both complementarily?
Yes, we keep switching between the two if there's an issue. Yeah, but TE primarily, we have Stam and Lucy on TE right now.
We use ICE, we'll see later, that to confirm anchor leaflet capture. Because sometimes you have shadowing or double shadowing, we'll learn our lesson. So if we had any doubt, we switch to ICE right away to confirm that that's been very valuable.
Interesting.
So you can see that here. So this is now the device. So this is the device going up. Pretty straightforward. One thing to note is that if you go from left one, beware of the pelvic brim and the spine. You might need to make sure that you haven't kinked the wire. And you can see now it's going in.
So here you can appreciate that offset a little bit, right, as you're going in, but the RA is pretty roomy there. Add a little bit of primary flex, pull the wire, and the device sort of settles down into the plane you want it to be in.
So this is where we're at so far. So we kind of exposed the anchor to 45, to almost 90. We pulled the wire. So now we're just trying to optimize our trajectory for leaflet capture.
Stam, Lucy, you want to say where we are right now from your imaging standpoint? Do we need to do something?
Yeah, we're trying to optimize the image here.
That looks
So you can
great.
see the
You
catheter
got rid of the shadow now.
Yeah, it's beautiful.
through the, and we have the orientation.
Panel
on the,
moderators, any questions? Please?
orientation on the green box.
Have you guys
Posterior,
added any
anterior.
depth at this point, or I don't?
Yes, good
Yeah.
question, Oshi. So we're about depth at 2.
2.
I think Yoshi and Gilbert have been texting each other. That's why Yoshi knows.
Yep. Gilbert can text with sterility.
Okay.
Good. You guys like it?
You scan good, release.
Yeah. Okay. We'll keep going then.
Yeah.
So it's very important, I think, here that the second operator, control the wire. Because if you pull the wire back, the valve can go a little bit more ventricular. If you push the wire, the valve can more atrial. Just be very careful with the wire, and then the nose cone as well.
Let's
But
check
also,
here
yeah.
before I do a full
Yeah.
flip.
Yeah, back drive. Okay. But yeah, also important that we've now pretty much very OCD about making sure there's no double shadow on MPL, especially on the lateral side. We had some challenges previously, so we want to make sure that if you have any double shadow, either recreate the MPL again or switch to ICE to confirm. Make sure you really capture the true annulus.
And this came with experience. We've obviously, this wasn't there before we implemented this in the protocol.
Yeah.
You have to move. Posterior.
Stay close.
Not that. This one. This.
We'll focus here for now because see how it's.
Mm.
Yeah, Dr. Kiri made a very good point here. Lucy, Stam, what do you guys think about the AP here?
The AP looks good.
Okay.
It's
The
more
problem is
anterior, no?
a little bit on the lateral part. The lateral is a little bit high.
Your favorite.
Okay, check here. I'm going to just
Keep on coming. Right.
settle it here. Okay.
So I think a very nice example of using NPR, that sort of standard view. On the top part of the screen, you have your posterior, anterior, and then you have your septal lateral. I don't know if all of you guys can see well in the audience that those are labeled for you, right? So we do it the same way every time. And now what they've also done, which is I think a nice feature, is they've stood up the tricuspid valve up and down, reduces a little bit of the cognitive burden. You're not trying
Moving
to
too
angle
much.
correct. You're just up and down
More
at 90
anterior.
degrees. And now you're looking at positioning. I don't know, Yoshi, what your thoughts are, Tarun, about positioning of the device right now.
I think that septal position is really good because that septal leaflet's always a problem. So I think that is, it looks like it's captured pretty well there, and all the trajectory looks good. The wire's in a good position. I think they're in a good
I think they're in a
state.
great spot, right?
Yeah.
AP also looks
Yeah.
very well, it looks very good as well.
Yeah, I did add a little bit of primary flex there. And, nothing can beat Dr. Kinney's experience in these things. I mean, we're looking at echo, but she already told me on fluoro, it looks a little bit off. So we just made that correction.
And I think as good as your imaging is, when you first start a case in tricuspid, I think Steve can tell you, it's always going to degrade when you have a big device in. Steve, how do we get away from the acoustic shadowing? What strategies do we have to improve these images?
I mean, these are pretty good so far. I mean, one recurrent theme is when you have too much catheter in, then you have to look through the catheter twice. When it goes across the image and then doubles back. That's a big deal. So always have just as much as you need and no more. That usually helps.
Ice for that.
Ice, okay.
Okay, flipping to ice.
Do you guys have a plan to pace the
Lateral
patient?
is okay?
If he goes into, do you guys have a plan to pace the patient if he goes into a heart block?
No,
we're not prepped,
yeah.
but yeah, if we need to, we can quickly go on. That's not an issue.
We haven't had that actually in our cases so far, knock on wood, so.
Yeah.
And the conduction here is good, baseline conduction. We're not very oversized.
Where are we?
You rotated.
Just gonna open.
So we're now
gonna switch
switching to ice.
So we'll often connect alligator forceps to the back.
Right, I was
So
going to
we-
say, what is your strategy
Yeah,
usually?
so we actually had a patient go into heart block in a live case, but we were ready. We were all set up.
Yeah.
Just,
Beautiful. Yeah, so you have the bare wire there. You can just stack the forceps. Yeah. I think that's what you guys are talking about.
Yes.
yeah, you can pace over the wire.
Let's go for a full flip here.
Yeah. So once again, now it looks like you've recreated your NPR using
On
ice.
ice.
Right, with a very similar orientation, that posterior anterior septal lateral portion of the valve.
Yeah, good.
It's good.
Want to switch to T now?
No, nothing. So let's just regroup here for a minute. Let's make sure ice is good before we go back to TE. We want to make sure that all leaflets are captured, and then we'll do the spin.
Yeah.
Okay, so
Yeah.
do you want to do spin on
Can you do the spin
on ice? Yeah, we can do the spin
Do
on
the
ice.
spin on ice.
Okay, let's make sure the image is good because the red box doesn't look too good. So we'll optimize that for you. And then maybe it will be good for Lucy and Stem to tell the audience and the panelists where the commissures are, right? Because remember, with the two commissures, if the two anchors straddle over a commissure, you're gonna see leaflet falling out of that anchor. So you do not want to put the cursor, between the anchors, because otherwise then you think you don't have capture. Do you have to put the crosshair? You see that what our echo team is doing when you do your spin, what we call a spin, you want to make sure the green line is actually on the anchor itself to determine whether you have capture or not.
And Lucy, maybe you could explain what the spin is for those that haven't done Evoque cases.
Yeah, so we spin from anchor to anchor to see, to confirm that the tricuspid valve leaflets are inserted into the anchor arms. We call that engagement. So just to confirm that the leaflets are engaged. And we go from anchor to anchor down in the blue box, and I would rotate here. Unfortunately, the image quality is not the
I don't like
best. Do you
the
guys want to do
position
this on ice or T?
Looks so good, no?
Position's very good.
There, look.
We can optimize this,
Okay,
or
now
we
it
can go
comes
to
up.
TE.
It's not really.
But we
Next
just
time
spin
the-
down here on the
leave
blue
ice.
from anchor to anchor so we can see leaflet engagement. And when we rotate through, your eyes are on the green box right-hand side. So you just look and make sure that you can see leaflet entering into that anchor arm. So we can try to spin here on ice. This is our home view. So we're at 5 o'clock. So I'm going to spin down here. And your eyes are on the top box green right side. I'm going from anchor. The leaflets here are engaged. The next anchor, engaged.
Be a little louder, please, so we can hear.
Yep. So we maybe,
Engaged, yeah.
we are engaged. We may be entering into a calm here with a little bit of shadow as well. So there's a little shadow here.
Yeah, we need to focus on lateral. I think septal, everyone agrees is good. I think
Engaged.
posterior, we're good, with maybe a little bit of a gap between the annulus, but I think once we do the full flip, it will be a little bit better once
Yeah.
the valve expands more.
Definitely
But the
engaged.
lateral is the key, okay?
And
1 o'clock, engaged. 3 o'clock.
Yeah.
Engaged. 5 back home, we're engaged.
What's it?
Yeah.
So I think everything looks engaged, with a little bit of shadow though.
So go to
Okay.
back to TE.
Go back to TE.
Yeah, I think
confirm.
that's reasonable. Yeah, let's go back to T. This looks, at least we don't have the double shadow here that we were concerned about,
Yeah.
but we want to focus on lateral.
So if you look where your TE probe is on fluoro, you can understand why you have that shadowing, right? Because you're right
Yeah,
on the
yeah,
device.
Right. Yeah, yeah.
Sometimes
right.
we'll actually use fluoro to optimize our TE position, and we'll also use fluoro to
Yeah.
optimize our ICE position to get away from the device.
You want it, Sam? Okay, hold on.
Fluoro is always the right answer for the most part.
Even for the echo people.
Yeah.
That's right.
Come on, Brandon, you gave him that one.
Thank you.
I'm going to get excommunicated from IE land now.
Okay, going back to T.
And so
Have
I-
a look at coronary landmarks in these cases.
That's right. So that's he'll rightfully point out that we actually look at the nice calcified right coronary artery, which sits in the AV groove. So we know at least the catheter is relatively perpendicular to the native anatomy. So that's an encouraging sign that we're not kind of out there.
Yeah, you know, when we did a few of the early Intrepid cases, we would actually wire the right coronary.
Good.
You know, if on
Yes.
CT it looked
Okay, it's
favorable,
looking
it
good.
helped.
Okay, I'm going to expand more.
Yeah. Let's go to a full flip here.
Full flip and then. Good.
Good.
Continue.
Keep going.
Good.
Okay, there's Sam.
I think the difference in
Let's pause here.
tricuspid,
Okay,
right, is
now
you
we
don't need to
look at the
pace.
real spin. You can see now on fluoro that the anchors completely, did a 180 flip. I think it's looking good so
I
far.
really like the way it's lining up with that RCA there.
Yeah, and also
Pretty centered.
the thing we have to check again is lateral, right? Because you see on the red box for the audience, that thing that comes down like from 1 o'clock to 7 o'clock near the anchors is a shadow. Okay, so that is the artifact. So we need to really make sure that once we've done the flip, that the anchors did not miss the lateral annulus.
Here.
Now, this is a very subtle thing, I guess maybe we've seen a lot of these images, is that you also look at the annular motion. I don't know if any of the panelists look for that. If the annular motion is very dynamic, you might not have that engaged. Versus if it's on diastole, it sits on the anchor itself, you see a little bit of a subtle difference in motion. That can be an encouraging sign. So
Stam, we have a full flip here.
Yeah.
Can you give me an answer about the engagement of anchors? Just
Yes.
do a quick spin, master spin,
You ready, Sam?
Yeah, let's go.
before causing dizziness in anyone.
2.
5 o'clock. You're calling it?
Yeah.
Okay.
What
5 o'clock.
5 o'clock, engaged,
What's happening?
6, engaged, 7, engaged, 9 o'clock,
Shadowed, yeah.
Hard to see.
yeah, we'll table that one.
Yeah, let's
Yeah.
table that one.
okay, let's go more. 10 o'clock, engaged,
Really?
11,
Guys, 1 second. Go back to 10.
10 o'clock.
Is that the commissure? Is that where the
Yeah.
commissure is?
Let's. I'm not convinced.
yeah, this outside. Okay, put it in, yeah.
Should we continue this time?
Yeah.
Yeah.
So just gonna pull back.
Go down.
Stay there.
right?
Keep it that view, please. Yeah. Just gonna retract the system there a little bit. See if we can get it down. But actually, check here again.
Yep.
Yeah. So this spin is the most important because
Still not sure.
no.
No.
Keep going.
Keep going.
Yeah, keep going, and then we'll revisit. Because the 9, 10 o'clock are shadow, so we probably need to use ice to see that. That was the lateral part that we're worried about.
12 o'clock.
Yeah, 12 o'clock, engaged,
Show that again, Stam.
engaged. It looks engaged.
Yeah,
Keep going.
I want to look at these three on ice.
Okay,
Keep going.
pitch back to ice.
Finish the spin first. Finish the spin first to be consistent.
Okay, this one, 1 o'clock.
Yeah, it's really buttressed against the septum, huh?
3 o'clock.
Yeah.
It looks engaged. 3
Yeah,
o'clock,
it's
4
really
o'clock,
hugging the septum.
4 o'clock.
It's pushing the septum. Actually, you see that?
Mm-hmm.
You know, in.
Back home.
All right, let's look at ice then.
Okay. Flora for a second. Let me
Yep.
get the ice catheter. Bad boy up.
Go low, Matt.
Yeah. No. Here.
All right, let's go live.
Yeah.
Let me clock, get you to the view. Get away from the catheter there. 1 second.
Nice.
Good. There.
There we go.
Check here, guys.
Do you want to explain before 3D or just 3D?
Well, we would like to go to 45, right?
Yeah, let's go. Let's get the best image possible.
So
and
what
then
we're trying to
explain.
say is that for the Philips ice catheter, for those you're not familiar with the device, 45 matrix has to give you the best resolution in terms of the way the array is set up. So that's why we asked our echo imager to try to get to 45 so that we can, when you do the X-plane, you have, good imaging on both panels. Otherwise, what happens is that you get a good imaging on the left side, but not the right side. So that could be a, problem.
So I'm going to lock this in place.
And that looks more promising.
Yeah.
But that's, we don't know which part of the lateral is it yet. So
Also remember the septal was a little tethered to begin with. Yeah.
that's right.
Okay, order.
So Stam, Lucy, you want to tell us what we're looking at here? Which side?
Setup should be the same.
Yeah.
PASL across the screen.
Good.
So
Put the names.
we can put the labels.
Put the labels.
Yeah.
Yep.
Any comments from the audience while we're doing this?
I mean, if you have such good ice images, do you really need TEE? These images are beautiful.
Yeah, they tell me these catheters are amazing. No one talks about the operator on the catheters.
That's true.
We've done a few ice cases for different procedures. We actually use our echo imager to play with the ice. And
Oh,
they,
yeah.
they
Yeah,
do a
that's,
better job
yeah.
than us.
They scrub in.
You say play,
We-
we say
I-
optimize.
Yeah. I prefer to stand on the other side and just complain, but
I mean,
yes.
on the previous ice image, I don't think any of the leaflets looked like it was pinned. So I'm pretty optimistic about this one, but
Right here, stop.
Stop.
Yeah, I just want to be extra cautious.
Are we
here.
10 o'clock? Are we at 10 o'clock?
Yeah, we're around 10.
Okay,
Yeah,
go
that
from
looks
9 to
good.
12. Let's check all of them.
9.
Thank you.
Lucy, you're spinning bottom left, but you're looking top right?
Yeah.
Yes. So
That's right. We're looking at the green box right side.
we're looking here.
it's 10.
Yep.
Yeah.
Up left.
What does the panel
Need
think?
everyone inside. One is okay outside.
Commissures we can miss, but we don't want two contiguous ones being missed.
This one looks engaged.
Yeah, looks.
Yeah.
Yeah, that one looks good.
I think Yoshi, it looks pretty good, no?
And
I do agree.
12
Yeah.
o'clock is engaged.
Yeah.
The
I don't know
te-
if one of the
That's
commissure
I
ones
like
missing.
it. More centered
Yeah.
now.
Is it that 9?
Let's clock the system there a little.
One of them.
No,
looks
It's
like.
that shadowing where you can't even
Yeah.
see it.
But if 2 out of 3
Probably
is
it's,
in it, I think we're
prosthetic valve,
good.
yeah.
Yeah, right? I feel like the teaching
I'm
is
pretty
one, you
optimistic
can
here.
always,
Right.
yeah.
Yes?
What does everyone think? Looks pretty optimistic
Okay,
here.
so stay in this image. We'll like to
We'll
peruse
release-
that. We'll keep going.
I'm releasing.
It looks great to us over here,
Looks good to you guys too?
Yep.
yeah.
Yeah.
Hold the
Okay.
wire, hold the wire.
And septal leaflet to me looks like it's engaged, right? It's not being,
Yeah, septal is
pushed
very
aside.
plastic because
Fully engaged.
the
Yeah.
anchor is actually pushing against the septum.
yeah, that's perfect.
But
This
this-
is the larger device, right?
This is a nice example.
52.
Sometimes it's just harder to get more confident.
Yeah,
You get what you get, and you got to decide.
Top.
And maybe we
Good,
can talk a
very
little bit
nice.
later about how the 52 behaves slightly differently, right, than the smaller sizes.
Are we too deep?
Yeah, good. What more?
It actually looks very good, guys.
We are 80% released.
But how about posterior? Posterior is deep, no? You don't think so?
Looks
Like
okay.
a double shadow of the anode?
I think it's a shadow, Gilbert.
double shadow.
Yeah.
Okay. All right. Just
Okay.
making sure.
Ready for release. Go.
Can see that
Okay.
well.
Yeah. Let's look at anchor heights for a minute, please. Yeah. So we really need to see the posterior on the green box.
Yep.
Make sure we there's a little bit of double shadow. We really want to see the annulus again with the leaflet insertion.
Posterior's here.
Yeah, I know.
Yeah,
So
yeah.
it's hard to tell where the annulus is. Anterior is easy. You can
Is
see
it
the leaflet.
possible for you to open up that posterior anchor?
There you go.
There. I just did a counter on
Okay.
my eyes
Good.
there.
See now we're more convinced.
Much better. Okay, I'm happier now. I'm much happier.
Anterior looks a little high, though, no?
Here, that's anterior, Gilbert.
Yeah.
Let's switch
Yeah,
to
let's
TE
do
for a
TE.
second.
He?
Yes, please.
Yeah. Oh, the flex more.
Hey.
This is really the rate limiting step for this procedure. So in terms of making sure everything is coaxial and symmetric, otherwise you're going to pay a price when you deploy. So the system is actually very intuitive to use, but you do need to make sure you work with your imager and confirm that. But you don't want to, be too long about making decisions either. So because imaging degrades, as everyone appreciates on tricuspid valve side, there could be esophageal trauma.
Yeah, PASL. You're in.
We looks good?
Yeah, looks great.
Okay,
man.
let's
Looks
keep
great.
going then.
Good. Okay.
Okay.
Let's keep going.
Going. Ready for release. More.
Mm-hmm.
So far, so good, everybody. Yep. Now you can see the lateral really
Yeah,
nicely.
much
actually.
better.
Yeah, it's in.
Good. Okay, gonna go for ventricular release here.
Everyone agree? We'll deploy.
Yeah,
Deploying?
looks good. Looks
Yes.
good, guys.
Not ventricular.
Everything looks great. Everything looks great.
Yeah. Mm-hmm.
Yeah.
Everything looks good. Everyone agree?
Yes.
Okay. Go for it.
Releasing.
Yep. Good. Very nice.
Beautiful result.
Okay, let me save this. Everyone breathe a sigh of relief.
I think that was Tam. 1 second. Let me.
Yep. We're going to count the
For a
clock.
second.
I have roll.
Yeah.
Yeah.
Okay.
Careful there.
Good. So let me just get the ice back. All right. So this is what I call the tricky part.
Yep. Here you go. Good. Good.
Pull this
You
back
can-
all the way.
Yep.
Yeah, you can see the
Yeah, do
angle
that
on the
flex,
sheath
yeah.
there, right?
Yeah, you see that, right? That's the offset, and then
Yeah. There's some tension there.
Yep.
yeah, we'll get everything off. No problem. No
Beautiful.
worries.
Okay, nose tongue is in the atrium now.
RV function
Yeah,
decreased
But
immediately.
no depth already.
Nothing.
Very nicely
All
done.
right. Thank you.
All right.
Okay, let's check. Color.
Done.
Cut again. They're ready in room 1.
Done. Okay, we are going to room 1. We have a tower there.
Okay.
You go.
Okay.
See you guys soon.
Very nicely
So-
done.
Very nicely done, yeah.
Okay, thank you.
Yeah, good.
I'll go there too. I'm with him.
You should talk.
Hello, room 1. You are live.
So we're gonna take this out. Obviously, the procedure is not done yet. So
I have to go. Thank you, guys. See you.
Now.
We're still there, okay.
Oh, we're
question
back. We're
about,
back in room 6.
These patients definitely will be on anticoagulation, right? Do anybody also
this
give
one better.
antiplatelet
Can I use
agent?
on that?
No,
Do any of us?
with the,
Yeah, usually just anticoag.
so with the bleeding complications being so high, one of the factors is
Yeah.
thought to be aspirin on top of anticoagulation,
Yeah.
right?
But in the trial, I think they did recommend use 81 milligram aspirin for at least 6 months. The other thing that we've been seeing in the cases that you have done is thrombocytopenia.
Do this. You pull this up.
We have had at least 4 cases of platelets. The normal have gone down to less than 70, day 2 and 3.
Oh, wow.
Yeah, we've seen that. Have you guys seen that?
I think we saw that with
And
TAVR also.
it was about 7% in
We
the
saw,
trial.
yeah.
Mr. Quickly?
We personally have not, but at the same time, you know, we were
can we just take it
talking
up?
that, you know, we saw it back in the days in
Is
TAVR.
Hold on one
Now we
second.
don't see it as much. Maybe we're not checking labs.
Yeah, don't pay attention.
Anything?
Okay, good.
Zero leak.
Yes.
Has to be
Okay, the
zero leak.
case is done here. Any other question in this case? Otherwise, we'll move on to room 1. Yes.
Can you just comment on the acute change in RV function? It looked like it dropped a little bit. I'm just curious how much.
Lucy, they're asking any change in RV function.
The RV function did drop a little bit. We're assessing it now. But the valve is very well seated, so no PVL,
was good.
minimal valvular. And the RV function will get quantitative measures, but just visually right now, it looks like it's mild to moderately reduced. So we started with a little bit of reduction. I think she'll be okay.
Okay,
Okay.
follow your programming, please. Can you lock this for me?
Very nice,
Let me hold it for a while.
stable deployment.
Looks like no change in conduction.
No, lock this. You need to flow guy and lock it and cut it. I cinch it down, but tap it again.
Even I agree. The RV does not look as happy as it was, yeah.
As expected.
Yeah, to a certain extent.
I think we're going to do a
Well, we
GLS now,
usually
too.
pre-have
see.
one mirror.
Can we have them come here? Can you call them? Let's start this case here.
So some of the discussion is, did we reduce RV function or did we reveal RV function? You took away the TR
21.
option.
Right.
So what have the panelists' experience been with 52? Does it behave slightly differently, this sort of extra large size, compared to the other Evoques?
We haven't done it yet.
Oh,
Haven't seen a difference, honestly.
yeah.
I think the smaller ones pop off.
That's what I've
Yeah,
noticed,
The
yes.
smaller ones pop off much
Yeah.
faster, so you just have to be very careful when you deploy.
Yeah,
The larger ones are actually a little more stable.
agreed.
Yeah.
Yeah, no, I think that's a good point.